Well, you know what, Dr. Hill, go ahead, because my Microsoft is still.
Okay. Well, good afternoon, everyone, and welcome to the first part of our two-part series on diversity matters in research. We are just so happy to have all of you with us this afternoon. We have a wonderful, wonderful program in store for you. I was noticing at the registration list, I didn't recognize as many names as possible, or that I was familiar with having attended previous programs. And so we're just so excited, but I would like to introduce myself. I'm Angela Hill, and I am a professor and the Associate Dean for Clinical Affairs at the Tuskegee College of Pharmacy. I also am the project director for We Care, and it's an acronym that stands for Work Group Enhancing Community Advocacy, Research, and Education. And our primary mission is really to link the research community with the lay community in hopes of enhancing the success of recruitment and retention efforts associated with diverse and underrepresented populations. And so we've designed many programs, and this is one but of a few that we've done where we try to educate the research community about the importance of culturally tailored approaches that again will enhance your effectiveness. So I'll come back a little later and tell you more about some of the other programming that we're doing, but I'd like to pass the baton to our executive director, Dr. Kevin Snead, who actually was the creator of All Things We Care. Dr. Snead serves as the founding dean for the Tuskegee College of Pharmacy, and like myself, he's also a pharmacist who still actually practices and teaches and does research, but he has a passion and a large heart for community advocacy. And he is especially invested in closing the gap of health disparities. And so he has led a team of us since probably now going on 15 years or more, to include Dr. Maisha Standifer, who was a part of the original team back when it was the Center for Health Equity. And she has since then moved on from University of South Florida to Morehouse School of Medicine. And we're so excited about having her here today. But we also have some of our partners here from our community-based organizations like Reach Up, and in the person of Dr. Deborah Austin, who leads the community outreach efforts for Reach Up, and they actually specialize in maternal and fetal health and all things related to family. And we also have the support of other staff members like Michael Morgan. And so we are so excited about having them here. So I'm not sure if we'll let Dr. Snead say a few words or get the program started, but I'm gonna allow at this point, Mrs. Edouard to take it from here.
Thank you so much, Dr. Hill. So what we'll do, we'll get the program started, and then we actually have allotted time for you and Dr. Snead to also give some additional words. So I'm just going to go ahead and share my screen with you all. And can everyone see my screen? Perfect. So good afternoon, depending on where you are. My name is Pascal Edouard, a We Care graduate student ambassador and a doctoral candidate with the University of South Florida's College of Public Health. I am also a visiting professor at Augustana College in Rock Island, Illinois. So to you all in Florida, I am missing the weather in Florida. It is definitely still cold up here. So to reiterate what Dr. Hill mentioned, we welcome you to the first iteration of the two-part series, Diversity Matters in Research. Co-representing this series with me is Dr. Maisha Standifer, who is the Director of Health Policy at the Satcher Health Leadership Institute at Morehouse School of Medicine. Fun fact, Dr. Standifer is also an alum of USF, where she received her doctorate in applied anthropology. And just advancing my slides really quick, and then I'm gonna pass it on to Dr. Standifer. So the purpose of the series is essentially to enlighten researchers on the historical and contemporary context of medical and research mistreatment among communities of color, contributing to distrust within healthcare and research settings. Today, our webinar will primarily highlight Medical Apartheid, where we'll be looking at the history of research and medical mistreatment among communities of color. We'll also delve into the implicit biases within the clinical setting and medical school curriculums, as well as go into the current perspectives on the mistreatment of bodies in communities of color outside of the healthcare setting, excuse me, and how that contributes to poor health outcomes. And then we'll end with policy implications. However, before we get into the meat of our presentation, I'm going to pass the proverbial mic to Dr. Standifer, who will have an opportunity to introduce the leaders of We Care, Dr. Snead and Dr. Hill, and provide them with an opportunity to provide us with a couple of words.
Well, thank you, soon to be Dr. Edward. I am again elated to be back, always with We Care as family, but also an extension of that to family members I see in the room this afternoon. But again, I thank you for being a part of such a great initiative. While I started, I was trained and taught at USF. Now I'm at Morehouse School of Medicine. But again, a great, I guess, in terms of extension and continually being kind of advancing some of the knowledge and some of the training opportunities with We Care. And without further ado, I will introduce the illustrious Dr. Snead, who Dr. Hill introduced a bit prior to Dr. Edward talking. And but I will start to talk a little bit about Dr. Snead and then also introduce a bit about Dr. Hill. Dr. Snead is a tenured professor and the founding dean of the University of South Florida, Tunisia College of Pharmacy. He also serves as a senior associate vice president for USF Health. Dr. Snead earned his Bachelor of Science degree in biology with a concentration in microbiology from the University of Central Florida. He received his Doctor of Pharmacy from Xavier University of Louisiana College of Pharmacy, and he completed an ambulatory care pharmacy practice specialty residency at Bay Pines Veterans Administration Medical Center. We are so excited to have Dr. Snead on this afternoon. He currently is the executive director of We Care, a community-based participatory research entity that strives to bridge the gap of health disparities by educating diverse communities about the processes and the importance of research participation. Dr. Snead also serves on the board of several organizations and participates in many community endeavors. I will also introduce Dr. Hill. Dr. Hill is a tenured professor and associate dean of clinical practice and past chair of the USF Tunisia College of Pharmacy. Dr. Hill received her doctorate of pharmacy degree from FAMU, also known as Florida A&M University, received postgraduate training in the neurosciences from the Neuroscience Research Institute, and holds a certificate in medication management. She is also a fellow for the American Association of Colleges of Pharmacy and a consultant pharmacist in the state of Florida. She serves on several advisory boards for the mentally ill and the underserved as well. One of her duties as the Associate Dean of Clinical Affairs includes her serving as the project manager for We Care. Again, we thank them both for continuing the great efforts of We Care. And Dr. Snead, the floor is yours.
Well, thank you very much for the very kind and generous introduction. I just want to thank everybody here. As has become customary over the past 2 years, and none of us can go any further without thanking Reach Up Incorporated and the dedicated support and friendship of Dr. Deborah Austin. I think it's a very important thing that's occurring here. And one of the most important things that's occurring is not even the presentation. The most important thing occurring here is your presence and your participation today. You know, if you really think about it, the backdrop of the pandemic has really shown us how effective it is when we actually have great communication going out into the community, or the opposite, when we have very poor communication going out to the community. So all of you taking the time now to learn the background, the foundation of clinical research is going to be very critically important moving forward. I'd like to remind everybody, number one, the pandemic is not over. You know, we are waiting any day now. It could happen today or next week for the World Health Organization to come back and declare that we're no longer in the pandemic, but more of an endemic around the coronavirus and SARS-CoV-2. But we know that other things are going to pop up in the future. And when they do, we want to make sure that we have educated as many people out in the community as possible so that we can, number one, communicate effectively what needs to occur, but then number two, hopefully keep many more people involved in the clinical research so that we can save lives. And we have to keep in mind, the number one thing we're here to do is to save lives. We want to make sure that everybody has an opportunity to live the fullest life possible, and to make sure that we are here for our communities, for our families, to make sure that children have grandparents and parents, and to make sure that the children themselves can grow up to become productive citizens in society. And everything that Dr. Edouard is going to talk about today, and I'm gonna give a shout out here, a special shout out to Dr. Standifer here in 1 second. But everything she's going to talk about is going to set the foundation of understanding upon which we can build upon moving forward, so that when we need each and every one of you to go out and be an ambassador in many communities, that we have the background of why it's so critically important that we understand the history of clinical research as it applies to people of color in our country, number one. And then number two, hopefully we can communicate more effectively so that more people will be involved in not only the clinical research, but solutions to save lives. And my final comment, as a professor, as a dean, there's no prouder moment than one of your former graduate students takes a leadership role the way we're seeing Dr. Standifer do today. So going back to our days, well over a decade now, Dr. Standifer, my goodness, I can't believe I still look this young. I can't believe, yeah, you still look like a graduate student, by the way.
Right. Thank you.
But it's a proud moment to watch you come and take a leadership role and kind of begin to pick up the mantle and run with it the way you have. So congratulations. And with that, I'm going to turn it over to my great esteemed colleague, Dr. Angela Hill.
Well, actually, we are going to allow Dr. Standifer and Ms. Edouard to lead us in our first discussion regarding diversity and matters in research.
Thank you, Dr. Hill and Dr. Snead. So I am going to begin, if my slides will advance. See, here we go. Yeah, so I'm going to begin with giving you a historical backdrop of medical apartheid in both research and medical mistreatment among communities of color. And then I will segue into contemporary forms of medical mistreatment in research. So many of us present today may be aware of the widespread medical and research mistrust among Black, Indigenous, and people of color in the US today. In a 2020 poll completed by the Kaiser Family Foundation and Anscape, consistently Black and Hispanic Americans are less likely to report that they trusted doctors, local hospitals, and the healthcare system in general. These statistics only confirm what we already know. However, why is this the case? One popularly known reason for this is medical apartheid. So what is medical apartheid? Medical apartheid is a systemic oppression and abuse of people of color within our healthcare system. Miss Harriet A. Washington chronicles this really well in her book, Medical Apartheid, The Dark History of Medical Experimentation on Black Americans from Colonial Times to the Present. So medical apartheid has existed since the time of enslavement of Black and brown bodies in medical offices and research universities, from the stealing of Black bodies from graves to harmful experiments on bodies, is recounted by Harriet Washington's medical apartheid. So I'm going to give you all, just share some examples of historical medical mistreatment among BIPOC bodies in research in history. And so the first example that I have is Dr. Marion Jones and the racist history of gynecology. So Dr. Jones Marion Sims is credited with being the founding father of modern gynecology. Sims, through the experiments on enslaved women, developed the vaginal speculum. This tool, commonly used during OBGYN annual visits, was developed by the experimentation on the enslaved Black bodies of women without their consent. Often, Sim performed these experiments without any anesthesia, despite how painful the experiments were. One of his victims, Lucy, almost died as a result of these experiments. Another example of medical mistreatment includes the forced and mass sterilization of women of color. During the 20th century, as a result of the eugenics movement, approximately 70,000 Black, Latinx, and Native American women were forcibly sterilized within 30 states in the United States. From the 1930s to the 1970s, approximately 30% of Puerto Rican women were sterilized as a result of the US belief that the forced sterilization would be beneficial to reducing Puerto Rico's population. Another example to highlight as it relates to the forced or mass sterilization of women of color includes occurrences of mass sterilization in North Carolina. In the 1960s, approximately 65% of Black women were forcibly sterilized. Among these women was a civil rights leader, Fannie Lou Hamer. In addition to this, during the 1960s and 1970s, the Indian Health Service was accused of forcibly sterilizing 25% of Indigenous women. Despite the 1973 Roe versus Wade Supreme Court decision, the reproductive rights of Indigenous women were largely ignored during this time. And lastly, I might also add too, that the forced sterilization of women did not just occur in communities of color, but also among women with disabilities as well. So next, I do want to highlight the most popularly known form of medical treatment among Black men. And this is the Tuskegee Syphilis study, which took place during from 1932 to 1972, in which case, about 600 Black men in Macon, Georgia, were enrolled in a study conducted by the U.S. Public Health Service to study how to treat what was known back then as bad blood. The men, in fact, had syphilis, but were not made aware of their status. Instead of actually treating the men for bad blood or syphilis, they were given placebos, and the progression of syphilis in the men was studied instead. Despite the discovery of penicillin as an effective treatment for syphilis in 1947, the men were never provided with the appropriate treatment. Next, I'm going to cover Miss Henrietta Lacks and the Hela cells, another popular example of medical apartheid. Henrietta Lacks died as a result of an aggressive form of cervical cancer. At the time of her death in 1951, cells were taken from her cervix without her consent or without her family's consent. Her cells today are well known as the Hela cells and were the first cells to be reproduced outside the human body. Hela cells are widely used in medical research from the development of the polio and the COVID-19 vaccines to the study of leukemia, cancer, and the AIDS virus. Sorry. Okay. And so my last example of a historical example of medical mistreatment among Black and brown bodies, or marginalized bodies, I should say, includes the experimentation on inmates. There are documented accounts of the mistreatment of vulnerable populations within the prison industrial complex. Examples include the human experiments at Holmesburg Prison. From the 1950s to the 1970s in Holmesburg Prison, Pennsylvania, the University of Pennsylvania and prison officials tested skincare products on inmates in exchange for money. These products included facial creams and skin moisturizers, perfumes, detergents, and anti-rash treatments. So these don't sound too harmful, right? However, in addition to those treatments or experimentation, they also did use more hazardous products to test on the inmates. And these included radioactive isotopes, dioxin, and chemical warfare agents as well. Another example, as far as the mistreatment of inmates within the prison industrial complex, include Project MK Ultra. And this took place during the Cold War, when the US feared that the Soviet, Chinese, and North Korean agents were using mind control to brainwash US prisoners in Korea. As a result, the US CIA approved the MK Ultra project in 1953 to come up with methods to control human behavior. One technique that was used during these experiments were the use of LSD for brainwashing and psychological torture. Experiments were completed in universities, hospitals, and prisons across the US and Canada. Many subjects were not made aware that they were participating in experiments or in experimental studies. Next, I'm going to highlight some examples of contemporary forms of mistreatment of BIPOC bodies in research and medical practice. The first example that I will highlight includes or addresses the disparate outcomes or maternal mortality rates among Black women in the US. There is a huge and concerning issue regarding maternal mortality rates among Black women in the US. Black women die at 3 times the rate of white women as a result of pregnancy-related complications. The 5 leading causes of maternal death among all women are preeclampsia or eclampsia, obstetric embolism, obstetric hemorrhage, and postpartum cardiomyopathy, in addition to other complications related to surgery or procedures performed during pregnancy. Non-Hispanic Black women, however, lead the numbers among all, well, I should advance to the next slide. Non-Hispanic Black women lead the numbers among all 5 leading causes of death. Additionally, preeclampsia is the leading cause of death among Black women. While some of these reasons behind the disparate maternal mortality rates may be the result of inadequate access to healthcare or experiences of racism and discrimination within and outside the healthcare setting, often Black women and women of color experience disrespectful healthcare or mistreatment and medical racism during their pregnancy, which can contribute to their high mortality rates. A popular example includes Serena Williams and her experience when giving labor too. And the last marginalized group that I will highlight as far as a mistreatment within the healthcare setting includes the Lgbtqia population. Often these individuals or individuals who belong to this population experience harassment and mistreatment within the medical care setting and are often refused healthcare services due to their sexual orientation or their gender change. So within the healthcare setting, individuals who identify as lesbian, gay, bisexual, or queer are refused to be seen by physicians, often because of their sexual orientation. Often too, what happens within the healthcare setting is that a physician might refuse to recognize their family member if a family member is a member of the LGBT or the lesbian, gay, and bisexual or queer population. In addition to that, the lesbian, gay, bisexual, and queer population also experience harsh or abusive language by physicians and also unwanted physical contact. And in this particular slide, what we see here is that the transgender population experiences discrimination and mistreatment within the healthcare setting at higher rates compared to the lesbian, gay, bisexual, and queer populations. In addition to being refused to be seen, experiencing unwanted physical contact and harsh and abusive language by physicians, they're also intentionally misgendered and refuse services due to their gender transition. So this covers my portion of like the historical and contemporary examples of the mistreatment of Black bodies. within the healthcare setting and within research. So I'm going to go ahead and pass the mic back to Dr. Standifer, who will continue.
Thank you, Pascal. And to talk a bit more in terms of framing, right, in the context of where we're coming from, particularly for this series, we want to highlight, again, the implicit bias within the clinical setting in medical school curriculums. And I think it's very important to highlight this because, as Pascal highlighted, we're talking about kind of the historical aspects leading up to the current implications and some of the results. But why is this? What has happened within the context of the United States, also globally? But then we want to talk about really when we're looking at healthcare delivery and healthcare access. And why is it such a disparate population where we're thinking we're one of the most advanced nations in the world? Why are we oftentimes, as we're related to maternal mortality rates and also infant mortality rates, comparatively beating out, I would say, developing or underdeveloped, as we consider underdeveloped countries and nations? So let's really unpack a bit. We only have a few minutes, and but we want to cover this over the next seminar series, along with continuing beyond the series, but go within your communities and your particular organizational settings to really kind of amplify what's happening and what's going on. And so we thank you for mobilizing and advocating for disparate populations, particularly marginalized communities and African American in particular. But we want to continue on. Next slide. So, as Pascal again indicated, we're looking at social, cultural, and structural barriers contributing to current health systems, right? The health system management, health system care, the receptivity of this from marginalized populations. Why do we need to understand the history before we go into the future, right? And so it is imperative really to understand what has happened before. We're talking about, well, why do we have these current populations? You know, what's the issue? And so when policymakers and other groups and organizations talk about, oh, why can't you just go to the doctor and get a checkup? It's easy. But we know many times it is not easy, and it is very difficult for populations that have historically been disenfranchised, ostracized, and even demonized in some spaces and some places. And I'd like to start off with looking at some mental conditions, right? We talk about mental health now with all that is ongoing within our current landscape, whether it be political, whether it be cultural, but we know COVID has amplified much of some of the mental impacts that many people are facing nowadays. And so when we're looking at kind of, unpacking what's happened and unraveling the stigma that's been around mental health, particularly in African American communities, we really have to understand, where does that come from? Where is it being emitted from? And often it's starting in medical settings and with clinicians. And so I want to highlight this to talk about the first public hospital of the insane and disordered minds. It was in Williamsburg, Virginia, and it was in 1773. And also to provide some context, what was in 1773? There were slaves, and slaves were admitted for treatment, which was, kind of novel at that time. But then they were also used for payment for treatment. Okay, where does that situate? Populations that have been historically disenfranchised and their bodies being used as payment and for a source of treatment. As treatment and a source of payment for those who are getting, services, especially for slaves who were considered, if they were defiant at any time, or they were considered, not being obliged toward the master of any kind, or if there were some uprisings and there were revoltings, oftentimes slaves, and linking it to Black bodies, were considered idiotic, insane. Often there are some studies highlighting that we're schizophrenic when you don't kind of abide by some of the mental health norms that were placed upon Black and brown bodies at that time. Historically, many people know about the Moynihan Report, the Negro Family, a case for national action, where it highlighted the violence directed toward African Americans and what was occurring in African American communities out of historical trauma situations and episodes, because we know we have to frame the experience of African Americans and immigrants also within the United States in the early 1900s from that historical aspect of what happened structurally and culturally. And so we know that the Moynihan Report was not favorable upon Black families and Black men, often providing some demonizing, which goes on down to historical aspects of why Black men, Black women, and even Black babies were treated and such, and still being treated as kind of a variant or a deviant type of population. Next slide. And so we really want to come currently looking at it, I guess we look at the last 10 years, the landscape for healthcare delivery within Black and brown populations. The National Healthcare Disparities Report in 2013 indicated that many predominantly Black communities have less access to quality healthcare services comparatively, looking at white populations. And why is that? Despite we being the most, I mentioned the most advanced nation, quote unquote, to speak in terms of healthcare services and scientific development. Why is that? Again, going back into the medical, structural, systemic, and systematically, those systems that have just been obviously not been very kind in terms of unpacking what many doctors and clinicians may also come into their own settings in the mind, whether it be in the clinical settings or on the operating table. When someone talks about, pain, Black and brown communities are treated differently. And we'll go on to talk a little bit about that. Next slide. Of why these perceptions are there. Again, as early as 1800s, we know that African Americans were unethically dehumanized, especially with some scientific experiments. As Ms. Pascal talked about, we wanted to highlight, again, the Tuskegee syphilis experiments, but we also need to talk about the Guatemala syphilis experiments that occurred almost simultaneously or preemptively for Tuskegee, when the Guatemala experiments were really testing medications as the syphilis study, looking at some of the ongoing impacts and effects related to syphilis. So there were studies across the globe that were impacting some of the experiments that were occurring here in the United States. Why is that? Again, we're talking about examples of slaves being used in experiments with pouring boiling water on their spines to test for cures for typhoid pneumonia, injecting African Americans with live cancer cells, even looking at dental extractions without any anesthesia, and even researchers using African American children to look at links between violence and genetics, and some detrimental medications that were used. So again, we have to look at this in the whole context. When you have researchers, where many of us are coming from the ivory tower and from those particular positions where, often vulnerable communities want to look at us, as second nature, saying, okay, well, what are you really coming into my community to do? When historically inoculations, vaccinations, or even shots were considered, dangerous, and we were experimented upon. And so we have to unpack this very important issue when we're talking about vaccinations or when we're talking about medications, and really informing populations that we really need to highlight from a community perspective, right, of what has been done, acknowledging that terrible history that has occurred, and then continue to educate, inform, and train those others. And I'll talk a little bit more about workforce, as Pascal highlighted in terms of J. Marion Sims and conducting surgical experiments on anesthesized female African-American slaves, but also Black infants. Okay, they were also experimented upon, and many of whom died during these experiments. Okay, next slide. To also, as I mentioned, highlight the Institute of Medicine, identifying healthcare provider biases and stereotyping and clinical uncertainty as factors contributing to healthcare disparities. Now, when the Institute of Medicine was the premier institute advocating or providing information and studies, research related to how clinicians practice and the landscape of what's happening in the field of medicine, and to report that there is implicit bias, often sometimes even conscious bias, when you're looking at stereotyping a individual, an African-American male who may come in, who may be possibly suffering from sickle cell, and states that they are in pain, grave pain, but you tell that particular clinician tells that patient, well, take a Tylenol, you're fine. And someone else comes in who is not African-American or Native American and comes in and states, I have a same issue, and they're provided, opioids or medicine to directly treat pain. There are differential factors impacting that. And that is what we're talking about, implicit bias contributing to disproportionate delivery of care and treatment in America. And it is still ongoing today. Now, this report was published in 2003, excuse me. And so I want to highlight, well, what about all of the history and all of the experiments and all the treatment that was ongoing prior to this time? Again, we talk about it is still ongoing, but there are strategies, and I'll talk more about this when we talk about policy implication. There are strategies and there are efforts being done federally, statewide in some states, and also local efforts that are occurring to dismantle some of the historical aspects of that embedded systemic and systematic issues that have been detrimentally impacting those communities of color. But when we talk about clinical treatment and the embedded curriculum of what is there in maybe pharmaceutical curriculum and also in medical school curriculum and all the allied sciences, what does that mean? And how do we go about treating those populations and hopefully, just totally dismantling and reconstructing new policies and new measures for treating those communities of color and those, again, who have been marginalized by those historical attributes. Next slide. So again, just to highlight what has happened in the past, which shows up in the future. The Flexner Report of 1910, some of you may know about this report, highlighting the medical school, medical infrastructure at that time, again, with that in that context, talking about the early 1900s. And the report resulted in 5 of the 7 historically Black colleges closing their medical schools. And this is, it's well known, is that the Flexner Report was supposed to just shine or, kind of highlight what's happening across the nation when you're talking about educating and treating certain populations, but particularly looking at medical schools. And when we talk about African Americans and their treatment, at that time, there, of course, in early 1900s, many schools, majority of those medical schools did not accept Black, trainees to go into medical fields. And so, of course, that emerged with some of the historically Black colleges opening up, kind of spawning out into medical schools, and some of them closed, as you can see. And so what does that say? Currently there are 4 Black colleges who have medical schools, possibly another one opening up soon. But again, looking at the workforce development, because it really had an impact on workforce. Well, when you don't, train or provide insight to already segregated and historically marginalized populations to go and treat, those particular vulnerable communities, then where do they go, right? And so this drastically reduced the amount of Black doctors, clinicians, even some nursing and some other fields that were able to assist with the healthcare of those disparate populations. And so African Americans do not have access to doctors that look like them currently. And so we need to bolster some of those efforts. And of course, we know that this is a barrier to treatment because there are reports also to indicate that when a physician or clinician or any provider looks like you, more of these populations are able to have better care and better health outcomes. Particularly, I want to highlight with African-American women who birth, African-American babies often. And so there were studies to show that when women have Black OBGYNs, they have better health outcomes. So what does that look like possibly when you're treating for other diseases and ailments and illnesses? Next slide. This concludes my presentation. I'll come back with some solutions that we can work toward currently and in the future. Back to you, Pascal.
Thank you, Dr. Standifer. So in this next segment of our webinar, I do want to just highlight some current perspectives as far as the mistreatment of bodies within communities of color. As we know, this happens not just within the healthcare or the medical and research settings, but also outside of the medical and research settings. And what are the health implications of the mistreatment, and not just mistreatment, but also the dismissal of the differences and nuances that exist among certain groups. For example, the Asian American population that I'll speak to in a bit. So in 2020, the world experienced two pandemics, right? Police brutality and COVID-19. You would think that we're not in the pandemic, as Dr. Snead said earlier, we're getting towards the endemic. It's not the end of the pandemic, but it's just becoming more, it's going to become more so like the common cold, if you will, in the US, right? So we're still technically experiencing the pandemics of police brutality and COVID-19 in the United States. When it comes to police brutality, as most of us are all too familiar with, communities of color experience increased brutalization of their bodies at the hands of law enforcement. Now, this does have historical context behind it. If we're familiar with how the law enforcement got created or was created in American history, we should all know that law enforcement was created as a way to control the movement of Black bodies during the time of slavery. And so depending on, where you stand on that, it still is the same thing currently today. And so according to data from Mapping Police Violence from 2013 to 2022, Pacific Islanders and Black individuals experience police brutality at the highest rates compared to other racial and ethnic populations. And as research accumulates, what we're seeing is that there's an increase, we're beginning to see that there's an increased association as far as the impacts of police brutality among communities of color. And what we're beginning to see is that there's an increased rate of poor mental health outcomes among communities of color who experience brutalization by law enforcement. So we're seeing increased rates of depression, anxiety, post-traumatic stress disorder, as well as suicidal ideation and attempts. In addition to discussing police brutality, I also want to talk about the importance of the disaggregation of data when it comes to health outcomes, not just the disaggregation of data, but also recognizing that oftentimes communities of color are left out of data, the data that is being compiled, as we saw with the COVID-19 pandemic. In the early days of the COVID-19 pandemic, there wasn't a lot of reporting when it came to the racial ethnic differences or who was actually being impacted among racial and ethnic communities. And so what we had is that a lot of public health advocates and practitioners are actually advocating for the release of this data. And once this data was released, it actually confirmed what we already knew. Communities of color were being disproportionately impacted by COVID-19. If you think about the context that communities of color live in the United States, are often the frontline workers. We live in households that are multi-generational. And so as a result of, these, the context in which we live in the United States, this led to an increased rates among communities of color when it came to COVID-19. However, this information is not new, or the realizing the importance of collecting racial ethnic data as it relates to health outcomes, and also disaggregation of data is not new. For years now, we've been having the conversations and advocating for the disaggregation of data when it comes to the Asian American population. Now, within the Asian American population, it's popularly known that Asian Americans tend to fare better when it comes to other racial ethnic groups on the socioeconomic levels and as well as health outcomes. However, once you begin to tease back the layers and actually disaggregate the data and look at the subgroups of Asian Americans, you begin to see nuances and differences in health outcomes. So for example, among the US-born Vietnamese women, we see that they're at an increased risk of dying from breast cancer compared to their non-Hispanic white counterparts. In addition to that, US Filipinos have higher rates of being overweight or obese and higher rates of comorbidities associated with obesity, to include diabetes, high blood pressure, and asthma compared to non-whites. So now I'm going to go ahead and pass the mic back to Dr. Standifer, who will speak to the policy implications and next steps.
Thank you, Pascal. Yeah, so as we talk about policy implications, why is that important? And here at Satcher Health Leadership Institute, our executive director is Daniel Dawes, who has created and amplified the perfect segue, I think, and we talk about political determinants of health. And so when we talk about, of course, we're highlighting some of the social determinants of health, all driven by policies. We talk about redlining, right? I'll highlight some of the acts and policies and legislative actions that have occurred to get us where we are today. But where do we go from here, right? And so if you can go on the next slide, Pascal. And I just want to highlight a few. Again, we could go on and on about how we can kind of move the needle forward when we're advancing health equity and some of the equitable solutions. We know that we have to unpack, again, the past in order to go forward the future. And so when we talk about policy implications, we know that the historic Civil Rights Act of 1964, imperative in terms of us starting to really kind of unravel what has historically been done and where do we go. And we attribute many of our actions that we're doing now, whether it be the Omnibus Act, which I'll highlight, and the Obamacare, Affordable Care Act, and some of the parity issues with mental health, we can attribute that to the Civil Rights Act of 1964. When we talk about the Omnibus Budget Reconciliation Act, we really want to highlight what has historically been done in terms of allocating funds. So you have to have funding from federal, right? For federal agencies and the government to really kind of work toward, and trickles on down to the state. And so that was really key when we wanted to highlight, well, we need funding to really advocate toward health disparities, health inequities. And so that was a critical act when you're talking about some funding efforts. When we talk about advancing particular components dealing with communities of color who are often detrimentally impacted by climate and environmental aspects. And so it was really key to President Clinton at that time issued an executive order where he wanted to highlight some of the actions that are really impacting environmental injustice that happens in minority and low income populations. So that was a key effort. But we also want to highlight in 1996, mental health parity and addiction equity acts. And some of you are seeing this in your respective communities in your states. Georgia actually just passed a Parity Act where it really kind of unraveled again what's happening disproportionately with individuals and communities of color, and really looking at some stigmatization that has occurred with mental health. And so it's also, kind of getting people in the community and even in churches to really kind of step up to the plate And so it was really good. Of course, we're talking about Affordable Care Act, where you're providing services and healthcare delivery to those individuals that are marginalized or when not, oftentimes not even able, working poor. We say not able to afford healthcare or insurance. So this again provided an opportunity to do that. And then I almost guess important to highlight them. And again, going through this as myself, we're really talking about Black maternal health. And that's the Omnibus Act of 2021, supported by Representative Underwood out of Illinois and Senator Booker. And it was just great to highlight and unpack all of this, the inequities. And so it was great to have this. We know that this actual act has been pushed by community organizations. Some of you may be here, some of you may be affiliated with some of these organizations. And it was over at least a decade that this Black Maternal Health Omnibus Act came to fruition and actually introduced, because it was, we know many of us talk to the choir, but it was because of evidence, of research to talk about the disparate population of Black mothers and infants dying at unprecedented rates, especially being in a really advanced, technologically advanced and clinical advanced country. And so it highlights the workforce efforts that need to be pushed. I talked about creating and training Black OBs and GYNs to really kind of cultivate what's happening. And when a mother tells you that she is suffering from pain, don't just advocate for Tylenol, but really get down to the root of that, right? As you would another mother, as you would your sister, despite her being another race or ethnicity. And so this is really getting down also to us addressing some of the environmental impacts, which is really it's a very packed act. And some of you may want to look at the act more intently. But it is really talking about when clinicians are being faced with asthma rates. Asthma being caused by environmental factors, COPD and cancer rates being caused by environmental and climate conditions. So we know that this is a very robust act, but we're looking forward toward advocating and mobilizing you and also academic collaborations, but then also training those efforts. And we have training efforts, and we have various training programs here at Morehouse School of Medicine where we are very tiered. We're looking at our training and informing some of the efforts of students, also with the residents, and also with the practicing clinicians. So these are some efforts where we're looking at some equitable solutions in terms of advancing efforts in terms of eliminating health disparities and addressing them. So thank you so much, Pascal.
Thank you so much, Dr. Standifer. I know you have to leave a little early, so I do appreciate your time, and you have a wonderful day.
Thank you.
I don't know if Dr. Hill wants to say anything before you leave.
Yes, I would like to say, Dr. Standifer and Ms. Edouard, that was wonderful, wonderful information. And you certainly set the stage for why these discussions are so important with our research community. And I'm hoping that if anyone has questions, they'll utilize the chat, and Dr. Austin and myself will certainly navigate them, and we'll forward any ones that Ms. Edouard can't answer to Dr. Standifer directly. But thank you so much for providing that information. And what we would also like to do is hopefully you all have allowed for our audience today to appreciate why it is that we have, allowed, why We Care is invested in the success of research, retention, and recruitment. And it's because of the disparities that they talked about, the examples that were given as it related to experiences of underprivileged populations that we feel have influenced the lack of excitement and enthusiasm about clinical research and trials. But we're working hard and want to work with you to try to break down a lot of these barriers. barriers. And so one of the mechanisms that We Care has come up with is we have a research advisory board that is composed of community members and some members of our We Care team that actually looks at proposals submitted by researchers and allows the researcher to allow us to work with them and give suggestions and insights on ways, again, to certainly connect with some of these groups, utilizing some of our people connections and contacts in the community. And so we would like to invite all of you certainly to consider submitting a proposal, and I will be putting information in the chat for you. If you have a study or project that you'd like to do, feel free to share it with us, and then we will explain the process and allow you to come and present to our group. But I would again like to say, if you have any questions for Ms. Edouard, this would be a good time to ask her now. The other thing, as Dr. Austin and Dr. Snead kind of join in on the conversation as well, we would love for you to to know that we have an existing library of present and past workshops that We Care has done related to topics concerning other aspects of research. So if you want to hear a little bit more about the Tuskegee experiment or study, as well as the Henrietta Lacks story, or if you're interested in learning more about COVID and care nuances, or some of the other disparate areas like mental health, Alzheimer's disease, and the like, we invite you to check out our website, and you can appreciate some of these, and they're kind of like our on-demand library. So I'm going to ask Reach Up if they would place that link in the chat for you as well, and we can certainly send this information to you directly, individually, and or again, you're welcome to access the We Care website, which we'll also post. So Ms. Dr. Austin has posted the We Care video library for you, and I've also posted the link for you to find out information and on the process if you'd like to submit any proposals for us to actually review and assist you in certainly connecting with the community so that you can diversify your research recruitment efforts. So I don't know, Dr. Austin, have you noticed any questions? Did anyone have? You all got a lot of compliments on the content.
Yes, and some, Ms. Edouard, and some requests as well.
Okay.
In terms of, but Dr. Hill, one of the things that we do see with the comments is that even though there are people, and I think Ms. Kim Smith really talked about it very, very eloquently, and that is that many of us have taken DE&I courses, and one piece that is typically not there is this historical piece, Ms. Edouard, that you and Dr. Standiford presented. So I think people are very, very grateful, you know, to have that historical background, because then you can recognize how things got to be the way that they are. Exactly.
Yeah, if I can comment on that too. You know, I mentioned I teach at Augustina College, and I teach undergraduate students. And a lot of the comments that I get, I teach a special course called Racism and Health Inequities. And I talk a lot about how like the racial context that we live in contributes to health disparities. And these are first year students and sophomores, and their minds are just blown as far as like, I did not know, like, why aren't we learning this? And so I think it's very important that we do really look at the societal implications, both historical and contemporary societal implications, as to how we got here in order to dismantle this, you know, this racist system within and outside of healthcare. We have to go back in history and actually learn, you know, it's a cliche saying as far as, you know, you have to learn from your past in order to do better. However, it's an honest saying and a reality. We have to learn from our past in order to move forward in progressive manners.
Exactly.
One thing I would just add quickly for all of our participants here today, again, great presentations. We're moving in times right now that are exponentially changing. One thing that I often talk about, and Dr. Hill probably hears it more than anybody, but the amount of technology, the amount of knowledge that we're acquiring is at the most unprecedented rate in the history of the entire world. So if you think about how much information we were gathering at 100 years ago, well, now medical information around the entire globe is doubling approximately every 20 days. And so what we don't want to happen at this current time moving forward is that all of these breakthroughs and all of this technology and genomics and everything else is happening all around us, and we're left out of the technological advances moving forward. I agree with many people and often many critics around the country that, many of the people, Dr. Edouard, those young people in your class, they may not be the ones who facilitated or are responsible for many of the injustices of the past. However, moving forward, we have an opportunity to make sure nobody's left out of the advances in healthcare moving forward, but we can't also leave ourselves out of that advancement. And I think that's one of the most critical things that we all need to walk away hearing. We don't want anybody in any community left out of the advances, the technological healthcare advances that can improve lives and save lives as we're moving forward. And so, again, I think the historical aspect will give a foundation of explanation, but we still have much more work to do to gain trust in communities moving forward so that we can all take advantage of clearly a new age in medical technology and medical healthcare.
Dr. Snead, if I could add to what you said, I know you and I both submit grants and all, and what we're noticing is that the NIH is being very particular about making sure as well that researchers are as inclusive as possible, because there's a need for us to know before medicines hit the market. We need to know how they're going to work in everybody and not discover it once we've spent billions of dollars to make a product and then it get out to the broader community and we discover that it causes life-threatening side effect. And it might be because of genetics, or it may be because of other factors that we learn. And that's what the research process allows us to do. And so I put in the chat, the link to the NIH website where they talk about the importance of diversity in clinical trials and why it's so important. So again, in as much as we've done so much reach out to the community, the lay community, trying to make sure that they understand the nuances of research and the protections that have been put in place and what the meaning of IRB means and some of the other technology and why they sign consents. We also want to loop back around to researchers like yourselves so that you know as well that we're a resource for you, so that you know that we have your best interest in heart and that we're trying to tear down some of these barriers, heal some of the wounds because of some of these experiences. And it's not here necessarily to point fingers or blame anyone, because many times our ancestors were involved and it was just unfortunately the times and the patterns and the trends. But as Dr. Snead has said, when with all of the advances that we have as it relates to technology, one of the things we can say is when we know better, we do better. And so part of the reason that we bring this kind of information to you, as sad as it is because we need to know. And if we, I think Dr. Standifer said, if we don't know our history, unfortunately, there's a risk of us repeating it. And so we want to make sure that people have a well-rounded understanding of situations and issues like this. And so that you can understand it's very complicated because there have been populations that have been mistreated in many, many ways. And so we just hope that you walk away understanding, again, why We Care cares, both about the research community and the lay community. And so as mentioned, we invite you to check out our video library. We encourage you to certainly capitalize on the future and present programming that we're doing, and know that we are here and we want to serve as a trusted resource for you. And we invite you to really consider submitting your proposals to us so that we can kind of help ensure your success in terms of research. So did we have any more questions come up? No?
You know, Dr. Hill, again, I think your comments are all spot on. You know, I just want to once again kind of almost reiterate back to all of our guests here. Sometimes it's not even about, you know, getting involved in clinical trials to find out later on that there's a problem with it because we didn't participate. Because, you know, we can identify that pretty quickly for a small number of people. The bigger problem comes in when we get out there and we identify that something is just not working for you. When you expect it to work and at the time that you need it the most, and not that we were scared of it being harming somebody, but we need to make sure that it works the way we anticipate it's going to work. And we've encountered that, and to be honest, we had the reverse happen. You know, you being my pharmacy colleague, you remember the medication Bidil, you know, for heart failure, and you know, the original clinical trial in that overwhelmingly had Caucasian participants, and it was deemed a failure as a clinical trial. But then somebody went back and looked at the small segment. They said, well, wait a minute, there's a small segment of people that it worked in. Who were those people? Why did that little blip occur? And then they found out that it actually worked much better and it was more effective for African-American patients. And that touched off a lot. That was really my entry point during that time period into health equity. So Dr. Hill, I appreciate you, just bringing that up for all of us so that we can understand how important it is to get people involved and moving forward, just so we can all, when we get sick and we want help, we want to know that help is going to work.
Exactly. So we also want to make sure that everyone knows that part 2 will be next Thursday on Cinco de Mayo from 12 to 1:30. We hope you'll come back and bring a friend. And we'll also be posting today's recording. So if you want to go back and review, refresh yourself on some of the details and the content, feel free to do that. So any other comments or statements? Okay. Well, we thank everyone, and hopefully we'll see all of you next week, and enjoy the rest of your day.